final speaker, and we're thrilled to have her here with us. I do have her bio, but she's going to introduce herself and incorporate it as a part of her presentation, so I won't duplicate her efforts. So please join me in extending a warm welcome to Dr. Gagnon.
So first, let's just determine the volume because I'm really loud. I'm one of 10 children, and I had to talk really loud to get what I wanted at the dinner table. Is this an okay volume? Yes. All right. I want to say thank you for having me here. I was here at Perkins as a child care worker in 1985 and 6 in the deaf-blind program with Martha Majors. So I love coming back to Perkins. It was a formative year for me. I went to the University of Vermont and studied psychology, pre-med. I had a fine arts minor, and I came to Boston and worked here at Perkins School for the Blind, and it was really my first introduction to visual impairment blind rehab, and I loved it, so thank you for having me back. So my career path was I worked at a VA hospital in Connecticut for 18 years, and I was at the West Haven VA. There are 13, now 15 blind centers in the VA system, and we, at that blind center, had 34 beds, and our veterans came and lived with us for 4 to 6 weeks for the interdisciplinary blind and visual impairment rehab. So I was the director of that program for those 18 years, and we received optometrists from all over the country and trained them there. I left in January of 2014 because of my concern for the caregivers of our brain-injured veterans and our veterans with PTSD, and now it's called PTS. They've dropped the D because they don't want to label it a disorder. That was just my personal story. That's what I'm doing currently, is running a nonprofit for the caregivers and children of our returning veterans because they have very few services. I would really rely upon them heavily in my history taking of my brain-injured veteran. With their temporal lobe damage, they had some speech challenges, with their short-term memory challenges and their frontal lobe damage. They had some executive functioning challenges, so the caregivers were critically important in my exam. And I started looking at them, and I thought, wow, they look exhausted. They have children on their lap. And I started asking them how they were and what they had via services at the VA, and frankly, they don't. This is important. I'm sorry it's not a huge tangent. It's important to these cases that I'm going to speak to you about how critical the caregivers were. I'm speaking today about acquired brain injury and some of the deficits that come along, visual deficits and others that come along with acquired brain injury. It sort of dovetails your cortical visual impairment conversation. However, there are different subsets of problems as were discussed this morning from the sort of the conventional definition of CVI, and some of the associated comorbidities are not always as literally connected to some of the acquired brain injury cases. And I'll spell that out as we go here. So I just want to tell you a story first about the beginning of my career and one of the first acquired brain injury cases of my own that a patient I cared for. In the Blind Center, we had patients that had, stroke, brain tumor resection, trauma more recently. This patient, toxic encephalopathy from exposure to chemicals. So all of these are definitions of acquired brain injuries. This gentleman had a leukomalacia from the AIDS virus. He had, and this was really at the beginning of my career when we managed AIDS very differently than we do today. So he was legally blind because of his cytomegalovirus in his retina, but he had a leukomalacia. Now, as a provider, I read that, I knew that, but the story is really interesting. So, in the blind center, I tell all my residents and interns to go pick up the patient from their room. We're floors apart, about 4 floors apart. The reason why I do that is, number one, I wanted my doctors to extend themselves and go to get the patient, but I also wanted them to observe the patient and move through space and start getting some clinical feeling. And we, at the VA, I think you all know, we have very rich electronic medical records. We can get to anything in that patient's record that we need to, a primary care exam, a neurology exam, brain imaging, any provider, it's there. And I make my doctors stay late at night and early in the morning to read that before they walk in the room. I do not want them, these poor patients tell their stories over and over and over and over. I wanted them to be well-versed before they walked in the room. So I had done my homework on this patient, and what he came in with in his exam record was hand motion, vision, and I don't think any other critical piece of information. At that point, that's probably the most critical information I could give you. So I walked into his room, and I said hello, and he perfectly fixated my eyes. So as an eye doctor of visual impairment for 18 years, I said, wow, he probably doesn't have hand motion if he's looking me right in the eye. So that was my first tip that something was off in my record. The second thing I did is I shook his hand and I did a little mini visual field test myself when I shook his hand, and I threw it a little low when I did that. And I brought it up to meet his hand rather than him meeting mine. So I knew he had some field constriction. I asked him to gather everything from his room that he came in with, glasses, sunglasses. I wanted to see what his photosensitivity might be. The way he walked around the room, he was clearly field constricted, just watching him walk around the room. So I offered him sighted guide. I got him down to my examining room, and I took my history. And then I started testing vision. And I'll show you in a minute some of the adaptive ways that we have this overhead rack in our examining room that holds a fine bloom chart. I don't use the ETDS chart. You know, there's a lot of conversation about charts you use. I'll show it to you in a minute. But when I started examining his vision, I was thinking, okay, small fielded, I'm gonna put up a small target. As you know, I wasn't sure his acuity, so that was a bit of a guess. I wanted to make sure he was fixating on my chart, so I waved my hand in front of the chart, so he got some hand motion so he would localize to my chart, and I started. And I could not get him to read that chart, so I thought, I made my optotype larger, I changed the distance in the room. Before we leave that one, are there any questions? And I want this to be very informal. Please stop me, ask me anything you'd like. Okay, thank you. All right, so being that trauma is one of the reasons to have cortical visual impairment, blindness, visual consequences, this case is about one of my patients that was in Iraq. And it's pretty fascinating because, again, I can't tell you how many of these patients I received that had no diagnosis of brain injury. None. And the reason why that happens today, to this day, is because you cannot scan a mild brain injury in the brain. Of course, Lotfi, you can hop right in here. Don't want to be giving misinformation, but you know, basically with mild brain injury, there's something called diffuse axonal injury of the neuron in the brain, and it really, with our current, scanning and of the brain, it's very, very difficult to pick that up. So the diagnosis of mild brain injury lies upon the clinician, and clinicians, I should say. It takes a team. And the reason why it does is, so you have to really, again, that title of this lecture is all about this. Ask well. Ask the questions well. So my interns, I made sure, and residents, that they knew every deficit from mild brain injury. Not only vision, of course they knew all the visual deficits because we made sure they knew those, but we wanted to make sure they knew the incidence of sleep apnea. They knew the incidence of vestibular and balance problems. They knew the incidence of cognitive and short-term memory problems. They knew the speech and language problems. I wanted them to know all of that because not that they were treating and diagnosing outside of vision, but they needed to look at the big picture that this patient was dealing with on a daily basis. So asking well is important. That's the beginning of the title. Listening well. What is their answer? A brain injured person, and please excuse me if you all know all this. I don't want to talk to you like I'm telling you something you don't know. This is how I would speak to my interns and residents. They didn't answer, let's say, an open-ended question very well. What's the quality of your life like? It would be better to say, tell me about your reading. Do you have these symptoms of blur? Okay, so this gentleman's story, let's make sure I advance these and we're all looking at the same thing here. Okay, so he was 51 years old. He was an Army medic. He served in Iraq for 14 months, and his unit diffused IEDs. So they were very, very at risk. He was exposed to 18 blasts. Okay. What I started to figure out at the VA in a very short time was we were getting under-referred for vision problems. What I started telling the team of the physiatrist and the OT, PT, speech, everybody, if they're exposed to one blast, I want to see them, these patients. If they have any history of blunt head trauma, I want to see them. Because you all have been talking all day about how fragile the visual pathway is. You know, you have millions of nerve fibers leaving the back of the globe of the eye, coursing to the base of your skull, crossing over some of those nerve fibers, some going straight back. It's very vulnerable to anything. And in 2007 and 9, I asked the DoD and VA to please host a conference on the visual consequences of traumatic brain injury, and we did. And at that conference, I had biophysicists and brain imaging doctors, and we all talked about how vulnerable the visual pathway was and why we saw so much of this. So imagine 18 IEDs. He was really, and his story unfolds in an interesting way. So just let me tell you the observation I made of this gentleman when he walked down my hallway, okay? Because this is also really, he had on very dark shades. He had on a baseball cap. He was very, very light sensitive. 79.4% of these soldiers exposed to blast are light sensitive. 79.4%. Why? What's the mechanism for that? We don't exactly know. I believe it's cortical. And that's my own personal opinion. Blackfeet, jump right in.
I was going to ask you, actually. I have no idea.
Some people say it's pupillary reaction. Some people say it's retinal, and they're looking for biomarkers in the retina. I personally think it's cortical. I can't give you the science behind that, but they come back, and this gentleman said as he was exposed to blast, his whole unit was calling home saying, send us darker shades. Can you send us darker shades? We are so uncomfortable. And it meant them seeing or not seeing. And those of you with light sensitivity know this is the case, right? I had to dim the lights in my room, and I used very specific customized tint sets, and I'll show you pictures of those too, that I customized the percentage of tint in them, and I tried everything, and I'll tell you, they do gravitate to the blue tint. There's something about the blue tint with brain injury. It's known to help the magnocellular processing in the brain, the actual visual processing. So this gentleman came walking down my hallway, and he had very dark shades and the cap on. His knuckles were trailing the right wall of the hallway. Okay, so any of us in this audience know, okay, so he had probably a visual field deficit to that side, right? But it was more than that. He had a visual field deficit. He also had a balanced vestibular problem, and that grounded him when he was walking. And we did some testing around that, and I'll tell you about that in a minute. So his was actually more than just a visual field deficit. Trying to think of anything else that I noticed just when he walked down my hallway. Those were the two most remarkable things. Okay, so he was twice unconscious when he was exposed to those blasts. That right there tells you he had a brain injury. You know, we know for sure he had a brain injury if he was unconscious. Mild is much more gray, the diagnosis. Concussion, mild brain injury, very, it's an obtuse diagnosis that you have to go looking for. So he had symptoms after exposure to the initial blasts. He had headaches, photosensitivity, double vision, blurred vision, ringing in his ears, and these were initially transient, but after repeated blasts, the duration increased, how long and how dramatic they were. So in March of 2007, he was exposed to a severe blast, and he was taken off duty for a few days. We can talk about secondary injury in a minute. So his symptoms got worse with increased blast. He still had headaches, photosensitivity, double vision, blurred vision, but added to that, he started having memory problems, and he started having sleep problems. The ringing continued. The recovery from these symptoms was significantly prolonged with the exposure to more blasts. So it was more dramatic, the symptoms, they stayed around longer. All right, so, what do you guys have up there? I have two different things on my screen for some reason. Okay. All right, so it continued. He had another severe blast, and he was taken off now for 10 days. So now he's reporting extreme photosensitivity, poor light and dark adaptation. So when he came in and out of light and dark, it took longer for his eyes to adjust. So that was significant, and we can talk about that in a minute. Still had double vision, blurred visions. He said, I had problems with reading. He had a burning sensation in his eyes. There's a high incidence of dry eye with these brain injured veterans also. And some feel it's a reduction in blink rate, how often they're blinking. And he fatigued when he was reading. After 10 minutes or so, he had a feeling like his right eye was not processing information. He was bumping into things on his right side. Remember, I told you he was trailing the right side of the wall. And things kept popping up on his right side. He had significant balance issues, dizziness. He had tinnitus, ringing in his ears, but he also said, my right ear, when I would cover his left ear, his right ear can hear only noises. He couldn't process words. How weird is that, right? So think about that for a minute. These patients have 20/20 vision, okay? Their visual deficits are visual processing, eye teaming. So they get passed off and not diagnosed because somebody might, refract them and say, okay, 20/20 vision, they're good to go. Well, no, their problems are different. They are more relative to binocular vision problems, the focusing accommodative problems, convergence problems, but also, so this to me, it really popped out in the history. I thought, that's so interesting. So in one of his ears, he only heard noises, he couldn't hear words. But when they tested his vision, he had a full range of vision. So it was like an auditory processing, much like he had a visual processing. And I've been on panels now at this time in my career of audiologists that speak to very parallel processing problems with brain injury as vision. So memory problems continued. He said, you know, I tried to come back, but I just didn't come back. You know, he couldn't put his finger on how he was different, but he just said, I didn't come back. He was in denial, he was waiting for things to get better. Now, of interest, his wife was a nurse in a brain injury clinic. How strange is that? It was like my son had a brain injury and I'm the one who diagnosed it because I found a convergence insufficiency. He and I have a weird, strange story of like fate. I was studying for my soldiers and I ended up going home and testing his vision because of all these things I saw in the literature, and I diagnosed his brain injury. It's sort of a strange story I can tell you later, but this woman was very astute and aware that she was seeing things in her husband that she knew of the population. So her observations in her history I thought were interesting. She said, my husband was an avid reader, but when he came home, he didn't read at all. So again, these patients, they might say, are you having problems with reading? No, because I don't. You know? I avoid it. So you need to ask them, were you a reader? Did you love to read? Are you reading now? No, why are you not reading now? What are your symptoms? What made you put the book away? So he was an avid reader, he's not anymore. She noticed his extreme light sensitivity. He loses his balance easily. He used to take long walks with our dogs. Now he takes very short walks. He was falling downstairs. He was bumping into things. Poor memory, losing his temper easily, sleep disturbances. His driving was unsafe. He wasn't seeing things on his right side. Okay, then my clinical observations, which I've told you some of, that he was extremely light sensitive. The one thing I thought was really interesting, when I was taking history from him, he fixated above my head the whole time. And I was like, wow, 20/20 vision, pretty full fields, why is he doing that? You know, I just was watching him. Every time I spoke, he looked above my head. Every time he spoke, he brought his vision down and looked me right in the eye. And it was so consistent. I finally stopped and said, you know, do you know that you're looking above my head when I'm talking to you? And he said, oh yeah, I know I'm doing that. He said, it is very hard for me to process what you're saying to me while I'm looking at you. If I release my vision, he could put all his attention into his hearing. So isn't that really interesting? It shows the vision with brain injury, the processing slows down in the brain. You know, you don't read as quickly. You don't process. Everything slows down a little bit. But he said, you know, actually his wife that worked with brain injury got him to a private sector brain injury clinic because the VA would not put brain injury on his diagnosis. So she fought and got him to a private sector brain injury clinic. And he said, oh, I met a physician there that told me, look, you have a brain injury. The physician said to him, I have a full tank of gas every morning. I can use my full tank of gas. You as a brain injured patient have a half a tank of gas, and you need to make it last the whole day. And they fatigue fast, and when they fatigue, they go down hard. So he would release his vision while he was listening to me because he was putting all that energy into hearing me and trying to respond cognitively. So then when he would switch and sort of put energy into his vision. It was really interesting. So I noticed he had poor balance. I noticed his trailing of the wall. He turned his head to the right when he went to listen to me. So I was just sort of observing what he was doing with his hearing again. He had a lot of searching for words and difficulty with speech, which was temporal lobe damage. He really had a tough time giving me history. So I had to ask very directed, specific questions. He fatigued after a very short time, became nauseous during some of my testing. It was really common for me to grab the garbage pail when I was testing some of their vision because with their brain injuries, they get nauseous pretty easily, and so something that we would have to do for them. So there are some definitions around open head trauma versus closed head trauma, and basically, you know, obviously with open head trauma, the injuries are more focal. You know, if there's a, let's say, shrapnel that goes into the brain, it's more focal to that area with the shattering of the skull, and of course if it travels through, it affects. But the closed head injury is like these IED blasts. You'd see them on CNN, right? And you can see this blast go off, and you see, and it almost looks like a heat wave that you see in the air. You can see where the wave is moving through the air. And all of a sudden it hits the Humvee, the windshield shatters, and the soldier is thrown back. And so all of that jostling of the head, the brain is hitting up against the skull in the front, the back, twisting and turning, and there's shearing of the neurons when that's happening, which of course affects the whole visual system also. So there is a primary response to brain injury and a secondary response. So the primary response occurs at the moment of the insult, you know, whatever's happening with the lacerations, contusions, fractures, shearing of the neurons. The secondary response happens weeks, hours to weeks after that injury. And it's a physiological biochemical response in the brain. And this is why you hear with sports-related concussion and sports-related head injury or any head injury, you need to keep yourself away from harm as best you can. That's why these gentlemen staying in theater, in war as long as they did right after their exposures to blast was horrible. Because the brain is very fragile during those weeks, and there's a lot of biochemical inflammatory response, and they're at risk. And if they get hurt again during that period of critical period of time, the damage is exponentially worse. So take your child out of play, take that soldier out of harm's way, and you know, really it should be, the critical period, is there a word on the critical period, Lotfi, at this point?
In terms of what? Oh, the delay period?
Yeah.
I don't think it's resolved because it has to be related to the impact of the injury. I don't think that's figured out.
It's
Yeah.
more individual, yeah. But critically important, you at least, you know, get them out of, because there's this cascade of biochemical reaction in the brain, and, you know, you really have to try to reduce any risk. So this is just a visual of the visual pathway, which we've spoken a little bit about, and how it courses through, you know, huge volume in the brain. These are the parts of the brain we've spoken to already: frontal, temporal, parietal, occipital lobe at the base of the back of your skull. So with frontal lobe damage, there's some visual processing problems that happen with motor planning, integrating voluntary movement of the eyes, abstract thinking, foresight, and judgment. So, you know, that's another interesting part of my working with brain injured patients. The first time I walked into one of my brain injured patients, he said, "You are so effing loud," he said to me. And I just went, "Yeah, no, I really am. You're so right." And they don't really inhibit always what they say, right? So I said, my intern looked at me like horrified. They just talked to Dr. Gagnon like that. And I was all good with it because I knew what was going on with this gentleman. And I said, "You happen to be right, you know?" And he then perseverated on wanting a Snickers bar. And, you know, I had read quite a bit about how the brain doesn't give the stomach and vice versa information that he's satiated, the patient's satiated. They've eaten, they're full. So honestly, during that, I wasn't even aware of that at that time with this first patient, but I finally turned to my resident and said, "Can you go buy a Snickers bar? Okay, because we need to get this exam done." Let's, you know, so there's certain things I learned. Temporal lobe damage, there's, you know, the temporal lobe combines sensory information and recognition and identification of objects. receives auditory stimuli and produces language. I told you with temporal lobe, they search for words at times. With the parietal lobe, there's some involvement with integrating information about object identification and where it is in space. And then occipital lobe, that's your primary visual area. And then there's, right brain, left brain things that happen and function. Right brain is more about the spatial big picture, the forest, and the left brain is more about temporal detail, like the trees. So, some of my patients would say there would be a set of keys on the table in front of them. Now, again, they had 20/20 vision. They couldn't find those keys on the table. They had a figure ground problem with their visual processing. They'd have to reach and feel for those keys. And so processing visual ground information can be very difficult also. It's just, obviously I'm not talking fast enough. Okay. So some of the ocular, sequela, I'd like to just, this is a lot of information on some of these slides, but let me just sort of bring this down to the 4 primary visual deficits. We already talked about photosensitivity, 79.4% of these soldiers being exposed to blast. The next highest incidence and visual consequence is convergence insufficiency. So it's very hard for these soldiers to point their eyes in to something they're reading and hold their eyes there. They can't converge their eyes and sustain their convergence and keep their eyes pointed to the plane of vision on the page. So what happens symptom-wise with and 42% of them have that problem, by the way, that have been exposed to blast. What happens is they see the print lift and move off the page. It literally floats off the page. They get a brow ache across their brow and headache. When they get more fatigued and it's more extreme, they'll go in and out of double vision while they're processing things up close. It's very hard for them to comprehend. They're working so hard to get their eyes to team there at that distance that those are the beginning symptoms. The first ones are the brow ache, headache, then the words lifting and floating off of the page, then the intermittent double vision, and then just frank double vision when they get tired. So those are symptoms we would specifically ask for. How do you do reading from the end of a line of a print to the beginning of the next line? These things. By the way, that was what my son had. I went home after I was at the VA until midnight one night reading all the medical literature when I put together that he had had a biking accident and I had brought him to the ER and he had a lacerated face, broken nose, clean CAT scan, I was told. As I was reading articles until midnight at the VA one night, I went, oh my God, this is Nate, this is Nate, this is Nate, this is Nate. All the other problems I realized he had that were in alignment with brain injury. I woke him up the next morning, I said, come here. My colleague was testing, I didn't examine my children, We typically don't, right? We don't want the responsibility of examining our family. But Nate was 5 when he had his biking accident. He was now 9, and he was really struggling in school. And they said he had ADHD, and they wanted to put him on Ritalin. So I said, Nate, come here. I tested his convergence. First thing I tested, I gave him a target to look at. I went to bring it to his nose. His eye troped. He had a tropia. His eye turned out way out here at like 10, 12 inches. He should have been able to follow my target almost to his nose, right on with both eyes. But his right eye turned out here at like 10 inches. So he was seeing double. If he had an eye that was pointed in one direction and an eye he was seeing double. So he was so uncomfortable trying to read in school, he was getting up and walking around the class. He didn't want to sit there and see double. So he didn't have ADHD. He had a brain injury and a convergence problem. So I had neuropsych testing done. He had 3 out of the 4 visual problems from brain injury. I had neuropsych testing done, we confirmed it, and we got him into treatment. And by the way, there's an efficacious treatment for convergence. that works. And it's been studied and published, so anybody who says that it's hocus pocus, we have the data on it. It's efficacious, the vision therapy around conversions. Nate went through 14 months. It should take 12 weeks. With brain injury, it takes a lot longer. But he can converge really nicely now. He's doing great. So those are two, vision, photosensitivity, then convergence is the next most common, 42%. Then next is, wait, let me think. The next is accommodation at 33%, which means that they have difficulty, these brain injured patients, focusing. So they have one of three problems, really. Either they excessively focus their eyes, so they have this hyper focus, which keeps it blurry. Or they have an insufficiency of ability to focus, so it's blurry. Or they have something called accommodative infacility, which means that there's a lag in the ability to focus and a lag in the ability to relax focus. So when they look at look at something up close and they go to focus, it's blurry, 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 it kicks in, gets clear. Their accommodation, which is, their eye's ability to get the focus at near. When they look to distance, it's blurry, 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 that's clear. They can't release their accommodation out there as easily, so school is really tough. Yes?
Is that related to the convergence problem you found?
Oh, it's a great question.
Thank you.
There is an association physiologically between convergence and accommodation. There is. So you really, for all intents and purposes with these patients, we measure them separately and together, those functions, and we treat them with a certain protocol. Both improve with treatment. I'm not sure if that's totally clear, but without getting into physiology, yes, there is an association between both. Yeah.
Does the accommodation, once it adjusts, does it stay adjusted till you move the distance again, or does it go back and forth? If I'm being
Also a great
adjusted, does it stay there until I look away and go back, or does it always readjusting even though it's the same distance?
That is a great question. I recognize you from Perkins years ago.
No.
I don't? Okay, we won't go there right now. Well, typically there's a lag in the focus, and when they get it, they can hold it unless they're fatigued. When with their brain injury and fatigue, they can't sustain. And there's a certain number of them that can't sustain it just because it's too taxing. So again, there's a way to treat that. But you can understand how disconcerting that is, because it's, no matter where they're looking, there's a blur period till the accommodation either kicks in or relaxes.
So just another question in regards to accommodating a vision impairment with this and that processing for people who have the trouble with focusing the vision and listening. Would they become more auditory learners versus visual learners?
Awesome question. Yes, and let me tell, yes, long-term possibly, but I can tell you short-term, we capitalize on their strength. While we're strengthening the visual system, we have them be auditory learners.
Okay.
And I'll tell you that in a minute, some of the treatments. But we purposely, while they can't converge and they're seeing double, and like I had a Marine that said to me, 27-year-old Marine, I really wanted to be a teacher when I left for Iraq. All I wanted to do in my life was be a teacher his whole life. He had multiple exposures to IEDs. He couldn't read when he came back. He couldn't comprehend. He couldn't focus. He couldn't trail. There are other visual problems I'll tell you in a minute. He said, maybe I can volunteer in a classroom. And I said, no, you're to be a teacher. And this is how we're going to do it. And so we started treating his convergence. While we were treating his convergence, we gave him devices that you all know the technology of. One of them is called the Doc Reader. It's part of Zoom text. He scanned in his documents and he just listened to them. in his case, I'll tell you about a few cases on how the doc reader works and why it's nice to have vision and auditory at the same time. But for him, we really had him learn auditory and keep up with the volume of his master's degree class through listening to print while we were strengthening. So we talked accommodation. The next most prevalent problem, which is nearly a third, almost 30%, slightly less, is ocular motor, pursuits and saccades, following a moving target accurately and looking from one target to another accurately. It's hard for these guys to do this. And the eye doctors in the audience, it's really interesting. When I started testing, talk about nausea and grabbing the garbage because they were throwing up, one of my first brain injured patients, I gave him a target to follow, and he was like, he had to hold my hand in order to fixate that target. And while I was moving that target, he'd have to close his eyes and open and refixate. That's the only way he could attempt that, to follow that target. And then looking accurately from one target to another is a problem. They either undershoot the target or overshoot it. So they don't quite get to it or they look beyond it. So that's a problem with reading print, So you do things for them. And with my son who had these problems at school, all that visual information on the page was way too much for me. There is no way he could have read that page of print. So what we did is like a typoscope, and many of you know what typoscopes are. You isolate a line of print. We did that with these brain injured patients. We covered the majority of the page except for a line of print with some black felt and got them to move it down so that they weren't confused. They can't, when you have a brain injury, you don't filter stimuli well. Okay, so too much visual stimuli is very disturbing. And that's why they tell you now after concussion and brain injury, turn the lights down, don't visually attend things, don't be back in school. Yes.
I'm going to struggle to ask this question, I'm not sure how to phrase it, but the trouble in the visually guided motor due to the vision of the shifting gaze, the depth, as opposed to the proprioception, like where is my hand? How do you distinguish, or do you distinguish those, or they're just married to each other? Or?
Well, there's some overlap in visual function. There are 6 muscles that go to each of your eyes, and those 12 muscles work together to have you team your eyes properly in space, vertically, laterally, even oblique angles. So those, it's sort of the eye exam starts with, of course, knowing, how to best correct them with their glasses, assess visual fields, loss and deficits, test how those eyes are teaming together, with convergence in space, etc. And how is the focusing system of the eye working? Because all of these things sort of play off of each other, and that's why the treatment of them is very individual. You address, get the best correction on that patient, get their photosensitivity treated, make sure you know what their visual field deficits are, especially if they have like hemianopsia, homonomous hemianopsia. So you just sort of have to define each factor, and some of them do affect each other. I don't know if I'm fully answering your question, but you sort of have to get them shored up with as many corrections as you can, and then bring them through the vision therapy, which is very individually, and then you biocularly treat first one eye at a time, and then you start getting more intense with the binocular treatment of coordinating of eyes. Did I answer your question?
Sort of, but I probably don't know how to ask what I'm thinking. That's quite a problem.
Latsi, did you get that question?
Unfortunately, I didn't know. My
Okay.
understanding was the coordination between the visual and the reaching movements. Is that it?
Yeah, and how, are you able, is there a distinguishing between when someone's not able to guide their hand to a target visually or from...
Correct. Yeah, absolutely. I mean, the key is that, for example, if you have, sorry, I'm going to
No, please.
So, I mean, the big issue is that you have a visual world, you have an auditory world, and you have a proprioceptive world. And those three worlds have to overlap. And certain brain injuries may impair one but not the other. They may shift one versus the other. So a person, for example, may reach out thinking that they're reaching where they're looking, but really they're not. So the key in these particular situations, what we think is happening is everything's scrambled. And the idea is how do you bring them back together? And I'm sorry if I may just continue, you know, it would seem tough in the case of that patient, for example, who says, I have to close my eyes to listen to you, because historically our thought was is we have to retrain the other modalities using the intact ones, and if they can't even keep their eyes open, for example, I wouldn't even know how you could try to re-register or reintegrate everything. I mean, that would be such a challenging case in my mind.
Yeah.
So again, I don't know if I answered your question either, but that's a key component, that everything has to line up.
Actually, dovetailing that, we can jump ahead a minute in this case with the vestibular problems, because I told you his wife was saying he was falling down the stairs, he wasn't walking as much. I noticed him trailing the wall. We did measure a visual field loss on the right side, but we also did some vestibular testing. We brought him to the VA in Long Island because they had a 3-part team. One, there was an audiologist on the team to test the hearing apparatus because it affects balance. There was a physical therapist because they wanted to see proprioceptively, was he feeling with his feet? Was he getting sensory information from his feet? Thirdly, there was an optometrist who looked at the visual processing of depth perception and, you know, different things. And we had already done all the visual testing, so we sort of just we went with the patient, and the optometrist found what we had found. What I thought was really interesting, though, first of all, he had really poor sensory perception in his feet. No one knew that.
Wow.
No one knew this man wasn't feeling well with his feet until we brought him there and the PT started testing. In addition, they put him on this device that's interesting. It sort of wraps around the patient, and it has a landscape, you know, sort of like a visual that looks like mountains and a landscape. And there was a balance board and we hooked him up to this belt and chains that held him in case he lost his balance. And it was so fascinating to me. We tested, they put him on the balance board and they purposely set him off balance, you know, so that he had to correct. And when his eyes were open, even though he had really significant visual problems and visual processing problems, he regained his balance pretty well. We put him in dark shades and we knocked him off balance. But thank God he had that belt on, because he would have gone flying. I mean, it was so dramatic how much his vision was actually compensating for his balance problems. To me, as an optometrist, I was shocked to see, even though, because I knew all his visual deficits, right? I'm thinking, well, what is his vision doing for him? It was doing a lot for him. So that gentleman, this was a big controversy at the VA for our blind center, because he was not legally blind. He didn't need a white cane. And they were very specific about you shouldn't give it to him because he's not legally blind from field loss. However, we did train him with a white cane, and the reason why we did is because the proprioception of the cane on the ground and stabilizing him made a huge difference for him, balance-wise. Like, he was trailing that wall because of his visual deficit, but he also was getting some sensory balance information. So the white cane made a big difference for him for both, you know, reasons. Okay, so back to this case. Excuse me?
Just a quick question. So Kara, this morning we were talking about the plasticity of the mind related to kids and CPI. You were talking more about compensatory techniques, using the white cane to pick up, you know, what the feet are missing in post-PTVS. Does the plasticity of the brain relate to brain injury, and if so, is it correlated with age as a injury?
Absolutely. Neuroplasticity is critical you know, that's why you have to get these patients into the diagnosis and treatment. Get them diagnosed and treated as soon as you possibly can, you know, get the brain rewiring and reworking, give the brain the, absolutely applies, critically important.
Can I ask a follow-up?
Yeah.
You talked about Nate's, and he had one symptom there was one symptom missing, and I'm guessing that it's the photosensitivity.
Right,
Am I right?
exactly. He had the other three.
And I think my theory is, it's the one difference that Nate didn't have compared to the soldiers, is that he was not in a loud environment. And I'm wondering, as you said, this hypervigilance, loud environment, chaos, just raises a certain level in their mind where they just become that much more sensitive. And essentially then when you put them in that calm environment, essentially what they're hearing is just noise in their mind. The rest in my mind seems just mechanical, the accommodated issue, the CI issue, and so on. Whereas the photosensitivity, much like the tinnitus, is just, they're kind of jacked, if you will. They're in a loud, chaotic environment. Imagine this guy, you know, IED blows up, he's now on a chopper, people are yelling, get a medic, doing this, he's going back to more chaos, and just constantly staying in this very, very loud, chaotic environment, and the mind just keeps, or the brain I should say, as you said, all sorts of things are changing. Whereas in the case of your son, it may just have been a quiet event. He fell, he was found, he got home, and the mechanical part obviously expressed itself, whereas all these sort of other things didn't. That would be my suspicion, because it's just incredible how common it is in these soldiers.
Huge.
We don't see it so much in civilian populations, but in the one population that we do see it in is pro athletes. Why? Because they get hit, coaches barking at them, get back in the game, doing this, the lights are on, you know, parents screaming, go back into the game. So it seems to me that that's that surrounding chaos.
Yes.
You mentioned the doc reader a couple of times. It's a really powerful tool, and you've come up with some almost miraculous applications of it. Two questions. Is there documentation on that? And in light of what we've been discussing today, do you see the doc reader as useful in phase 3 CBI?
Gosh, I need to give you a disclaimer. I am not a technology guru by any stretch of the imagination, so please don't feel like I'm endorsing this over anything
Well,
else.
I'm very familiar with it, and I think that I'm impressed with your success with it, and I'd like to pursue it more on my own, so I'm just asking if you can elaborate a little bit on it.
Well, what I knew about vision with these, like, there's another case that comes to mind right away too. A woman who had a brain tumor that was resected, and she had very similar problems with decreased contrast, part of her visual field. I think she also had a hemianopsia. She also needed some magnification. She would fatigue easily, so she could switch between using her vision and listening. So those cases I did have success with, but what I don't know, you know, is there something else out there that is as good or better. But I can tell you with those cases, I loved the features of, because I could isolate the left side, right side, middle, by line, I could mag it up, I could change the polarity of you know, white on black. So it was very helpful for those patients.
I think, and I'm not a tech person either, but I think there's another consideration is this an acquired injury where the person's already a reader versus a congenital malformation or early injuries, we would say with cerebral visual impairment, that they're non-readers. And so what would be the appropriate technology for the individual needs? And I think that's a consideration to take.
Excellent point. Absolutely, no doubt about it. You know, you different populations really, different challenges.
Another consideration there is whether you interact with the material, or are you just listening to it?
Right.
So
Just
you
what's the cognitive load? What's the physical load? All yes.
Right, so
Right.
different software. That would be a good thing either way, because it's better than getting nothing. That's my point. There's a big debate about whether reading can be accomplished through listening or it requires braille or print. Right. Okay, so we're talking about things in phase 3 that aren't, that we're hoping for a lot more success than we've happened so many flexible possibilities with state-of-the-art just current technology that I think we need to look at. And it's a matter of blending the auditory and the visual information, or stopping one and doing the other, and alternating, giving some executive control over the technology to the user.
And based on
Maybe
fatigue,
one more question, then we'll allow Dr. Gagnon to, go ahead.
yeah, based on fatigue, they might not want to use their vision at the end of the day when they're really tired. And listen, because they're gonna go in and out of double vision more readily if their eyes aren't teaming because they're tired.
Go ahead. Final.
I just want to refer back to the children. It's different for adults because adults don't have standards by which they're judged, whereas the Department of Elementary and Secondary Education has very specific standards for children at school that they must meet, which means that those that are doing the intervention have to meet the criteria set forth by the Department of Elementary and Secondary Education and followed through by the school districts. So you have to account for, you can accommodate only so much, but a child has to demonstrate their reading comprehension, their written comprehension, and how they do so still has some work at the Department of Elementary and Secondary Education level. Because those standards are the standards that teachers and PDIs have to use when educating their child.
I'm not, so does that mean that referral, oh, we're talking about the technology
Yeah,
element?
just the differences between the adults, you can be more creative because you don't have
Oh, I see what you're
by
saying.
which they have to be
I
judged
see.
in school.
Okay.
So it's looking at other softer things that aren't accommodated, like scheduling your reading sessions for the morning, and then auditory for, if you're being tested for reading comprehension, you need to actually physically be reading. Or if it's just comprehension itself, then you can be auditory listening. And you have to look at what the criteria they have to judge on first before
For the testing.
for the testing.
Mm.
It's different for kids because they have to meet certain academic standards.
Well, hopefully they can give them some of the compensatory things
Yes.
outside of the testing.
Getting much better. Getting
Good.
much better.
That would be the case for my son. I wouldn't allow him not to,